The question that I end up having to discuss with my patients a lot is, the question of like, you're talking all this stuff about low back pain. Why is this different from, every other pain I've ever experienced or been told about, as far as the care plan goes by other providers.
Right.
And like the thing that was on my mind is, like low back pain is different from other pains, but instead of going down that whole rabbit hole, I kind of got to thinking like, well, of course with the knee, I'm very interested in anatomy, but with the shoulder, I'm also interested in anatomy, but I don't play this trick on myself where I think we have any tests to kind of differentiate the anatomy, and so all these different realities require different set of tools. Like the hip is the same thing. Where is anatomy very important for that care plan? Extremely important. Do we really have any kind of good tools to differentiate in the office one anatomical pain generator from another? Not really. And that has to sort of dictate, how we're going to approach this, as opposed to something where low back pain, we're like, I don't care. I don't care at all which tissue is generating the pain. I was going to say, like, I think that some of the differences there are the anatomy of the spine in general. Because like I think we can think of the neck in very much the same way, and even the thoracic spine is just that it's a bunch of tiny joints stacked on top of each other, right? So, if we talk about knee pain, we have, two joints, shoulder, we can talk about the ball and socket of the glenohumeral joint. It's bigger, it's a bigger joint, and it's sort of easier to dissociate movement from that joint, from one joint from other joints around it, where the spine, we tend to even just say like low back, like that's a joint. Well, that like the low back is a multitude of joints that we're just talking about very generally. So just in general, we speak about spinal stuff in more general terms because things are closer together. And I do think it's harder to differentiate, separating out one joint from the other. But on top of that, I mean, I think the other piece of it is like, it's good to know your anatomy, no doubt, right? Like we need to have this internal picture in our head of anatomy, kinesiology, like how things move in some type of, kind of perfect world idea, like to have a starting point of what we're looking for. But the reality is when we get a person in front of us, we don't really have the ability to confirm that their pain is coming from some type of structural pathology. It's a guess at the most based on the way that we were taught to kind of think about the body. So if we have some provocation tests in the shoulder or the knee, we now have a better idea of the pain behavior, but we don't necessarily know if it's because of a specific structure. We might be able to get closer to the idea of that, but again, that's a jump that's being made. And I think that's what the evidence would show is that there could be an MRI that shows damage but have no pain. So like if we're doing these tests that provoke pain and saying that they provoke pain because there is structural damage, that's a jump being made in our own understanding. Yeah, absolutely. And I think the shoulder, is a really good indicator, like a good demonstration of what you're talking about. Of like, you need to know your anatomy before you can start dismissing, the tissue generator and low back pain. Like you better know that anatomy. And I think in the shoulder, like we can do this thing and go, hey, I'm going to create a care plan based on your, provocative movements and your available. Okay, that's fine. But like, I'm not going to do a Hawkins Kennedy and then go, okay, well, I guess we're not going to do an upright row because like, you better know, okay, well, you know what, if it's the rotator cuff being sensitized, I think we're going to find this, that, or the next thing. Otherwise you are just like, hey, let's have like 4 painful sessions and then I'll figure out this pattern. You need to, I maybe I pull on young me and pull out these like mistakes I've learned or these thought patterns 5 years on, 6 years ago. Oh, why was I thinking that way? It almost becomes a form of like accidental laziness where you go like, I don't need that anymore because that's not going to dictate. No, like, no. You need to know it. And then once you know it, then you can kind of start downplaying its importance, you know,
Yeah,
but you
absolutely.
have to have it there.
Right. And I think there's a backtracking from the possibility of a certain structure being involved in some type of theoretical diagnosis, and then how you would look at, movement limitations. Right. So if you use the shoulder is a good example. I mean, it's a simplified idea, but you have four rotator cuffs, right? You have the supraspinatus, and you have the external rotators, and you could, if you just look at the anatomy of the scapula, you have the spine of the scapula. Right on top of that spine is the supraspinatus. Right below that is the external rotators, right? And just the idea of separating out, what's being more involved can be a useful thought process, right? Like the idea of saying that the external rotators pull the head of the humerus down while the supraspinatus pulls the head of the humerus up, and then looking at people move and saying, well, you're not getting good rotation in your shoulder as you're lifting up. It's obvious that you're kind of riding up, where otherwise we would want you to be creating more rotation into external rotation when going overhead. So the underlying idea there would be, if we can't get that the way that we want it to be, then we might be creating more activity that would irritate a supraspinatus. But we don't know that that's true, but it's a nice running theory.
Yeah.
Ultimately, what we're seeing, though, is that there's another way to move that might be less provocative, right? And we can kind of go, and then what we have to do, though, ultimately is test out if that's actually true. Like, we have to get people to move in the way that we are hypothesizing would be better, right, and see, does that actually limit your pain? Because if it doesn't, then we have to think differently. We have to, no matter what an MRI says, we have to reevaluate our movement thought process.
Yeah, you are exactly right. Like, you need to be able to form a differential diagnosis. It doesn't mean we have to defer to this tissue damage based model that's going to determine everything in terms of protecting and resting and a lot of that more fear based vocabulary. But yeah, the mechanics, the biomechanics and the knowledge of the anatomy, that is going to change your care plan for sure.
Sure.
Like you said, you have to be able to hypothesize.
Right. Yeah. And it is, and I think it's important that it is a hypothesis. It's not a truth. It's, right. And like we learn anatomy, we learn it statically, mostly. And even the more that we will begin to understand it dynamically by looking at sort of, inside the body while people are alive and understanding fascia and stuff like that, we're not doing that in the moment where we have somebody in the clinic, right? So it's always extrapolating information that's been done elsewhere and saying, well, that seems to fit with this current person that I'm seeing in front of me. But I mean, I just feel like the pain provocation, the pain behavior that somebody comes in with is always the thing that trumps everything in the assessment process. And understanding what is that behavior and having an underlying biomechanical theory of why that might be is valuable, but it's ultimately like, if the pain shows you something different than your biomechanical theory, you better be willing to change.
Yeah.
Because and I think there's a lot of therapists. There's also a lot of patients now, a lot of the general population that's looking for a diagnosis based on structure, so that they can go to WebMD or they can go to Google and look that up and see, like, what do I do? Like, I want to know what this is so I know exactly what to do. Yeah. And unfortunately, that's a huge problem, because that's way too static of a thing. And I do think a lot of physicians or a lot of people that aren't in the rehab process, they're in the more diagnostic, radiograph, right, image process. They are also in that mindset because they don't have the opportunity to see things change based on movement and then be able and need to adapt right within the clinic, right? It's just very different processes. So we as movement therapists have to really be able to have that understanding of what's being discussed when people are talking about biomechanical diagnoses, but also have our own, differential diagnoses in our head. that are totally different.